The next item on our agenda today is going over some alternative methods for pain management. So the first person that we're going to have come up is Heidi Gonzalez, and she works for Lakeland and has for the past 7 years as a physical therapist. So please help me to welcome Heidi.
Hello, it's a privilege to be here with you today to talk about physical therapy and what we can do to help people in pain. So as far as the definition of physical therapy, what I like to say is we are musculoskeletal and movement specialists. And to begin talking about physical therapy, I kind of want to start, before I say what it is, I want to debunk a couple myths that I hear a lot about physical therapy. One of those things is that physical therapy is massage. That is not true. I didn't go to school for 3 years to be a massage therapist. Not that massage therapists aren't good, I think they are. But that is one thing that PT is not. The other thing that people will say about physical therapy is it is only exercise, and that is not true as well. We've got a lot of tools that we can use to treat people and help people with pain. Exercise is one of those things, but not our only tool. The other thing that I think pertains the most to opioids and people in pain is that physical therapy is always painful. I've heard it all. PT is physical terrorists or pain and torture. I'm sure there's more. You can tell me afterwards. But I think that's one of the things that I think is false. Some things certainly are going to be painful, and I talk post-surgical, things like that. But it doesn't necessarily have to be painful, especially for people with chronic pain, which we'd be talking more about as far as opioids go. So as far as the tools that we can use, we do use soft tissue mobilization, a form of massage, probably not the feel-good massage most people are hoping for, but that's one way. Strengthening exercises. The thing that I think sets us apart, say, from just going to the gym and doing your own exercises is the evaluation process that you go through when you come to physical therapy. So it's an hour-long appointment that we have where we discuss pain with you, what you want to do, but also testing specifically specific muscles so it can be more directed. It's an individualized exercise program based off of your strengths, weaknesses, things like that. Joint mobilization is another tool that we can use to get people moving, especially in people who've been restricted in motion for a while. Modalities, including ultrasound, electrical stimulation, spinal traction. So I could bore you with all the facts about that, but the thing I think that is most important that I found in my own practice is education about pain, actually. And I think the thing that is most difficult for a lot of people is that they're fearful of pain. And anyone who's experienced those extreme levels of pain will understand it's scary. No one wants to be there, right? But the thought that referring someone for physical therapy is actually going to make that worse is not necessarily true. So one of the things that will happen is I'll have, say, 2 types of people that come into physical therapy. There's probably more, but there are the people who come in who have basically no pain at rest or very little pain, say 3 to a 5 out of 10 coming in. And the discussion that I have to have with them is, in order to get moving, in order to improve your function, you may have some pain, but it doesn't have to be horrible amounts of pain, right? So usually what I'll tell people is, if you're doing your exercises, your stretches, these specific things that I give you to do, you shouldn't be going much above, say, a 5 out of 10 out of pain. So I think people come in thinking, well, it's going to be miserable, they're going to torture me, and of course, some of you may have had that experience as well. But I think we have to choose an acceptable amount of pain. So a lot of education about it's going to hurt some, this should get better, but to expect it to not be painful at all is not realistic. So I'm setting realistic goals for people as well. The second type of person that comes in to physical therapy are those people who are in 8 out of 10, 12 out of 10 pain. It doesn't go higher than 10, but okay. And I would say those are the more challenging patients. The thing that we'll talk to them about is after having pain for a while, it actually changes your brain. They talk about plastic changes in your brain after having chronic pain. And so we really have to discuss with those patients setting functional goals for them, and also talking to them about, can we find ways to get you moving that doesn't actually increase your pain? So the term that I'll use often is hurt does not necessarily equal harm. I think that's the other thing people are nervous about. If it hurts, am I making it worse? And that's one of the reasons to come to us, so we can kind of guide you through that process, like what kind of pain, educating about different types, and how we can, how that can help or hurt. I think the biggest thing with people with chronic pain or those high pain levels, I'll use an example. I have a woman right now, she's probably in her 60s and has had chest pain, musculoskeletal chest pain for, I'd say, probably close to 2 years. And her kind of baseline pain level when she comes to see me is about an 8 out of 10. So for her, I've been seeing her for several months now. I'm sure she's on some, I couldn't tell you right now, I'm sure she's on some sort of pain medication. But what we've had to discuss in our therapy sessions are, can we do things to get you moving better that aren't going to make you worse, right? If you've been at this level for this long of a time period, obviously my goal for you would be no pain at all. But we have to set realistic goals. So last time I saw her, one of the things we discussed is, can we get you moving? Can we get you stronger so you can go do the things that you enjoy, right? I may not be fixing you so you have no pain at all. And some people that does happen. But there are some people that leave me and still have pain. But, especially those people who've had pain for a long, 10 years or so. But can I get you doing the things you enjoy? She wanted to walk. She enjoyed going outside, going for a walk, but was fearful, is that making me worse, right? And her endurance of that was not very good. So trying to educate her on what can we do and can we get you doing the things you enjoy? I think the other benefit for patients with chronic pain as far as that goes is talking about the drugs that your brain actually produces when you're exercising and or doing the things you enjoy. You get those endorphins, serotonin, all of those things that your brain produces while exercising or doing things that are enjoyable. The other thing that I will often tell my patients is, again, those patients that come in that have, I would say, more of an acute type of pain. I had a woman the other day who actually fractured her ankle. She had pins in her ankle, came in probably 3 months after her surgery, and they wanted us to take her out of her boot and start moving that foot, right, after 3 months. And so one of the things that I had to tell her is by actually moving that body part, whatever it is, ankle, foot, neck, back, we're sending signals to your brain saying, this is okay to do. This body part is okay. We're actually reversing it, not just top down, right? Brain to muscle body part, but actually the reverse, right? This is okay as long as we're in that acceptable amount of pain. The other thing that I had to say to her as well, and I'm not a psychologist or a social worker, but I did have to say, you're going to have to do a little bit of self-talk as well as you do this movement, especially for people who've had a traumatic injury. You have to say to yourself, this is not hurting me, because your body will be like, what's going on, right? Why is that part moving, especially after being immobilized or having pain for so long. That's another big thing is really having people work on, I guess, the psychological component to it, because that's huge as far as pain goes, and especially chronic pain. When I was contacted about this presentation, one of the things that Mindy had suggested was to talk to you guys about things that I see as kind of my pet peeves in physical therapy. And some of this may be more pertinent to, say, primary care physicians or nurse practitioners. I don't know how many of them are out, of you are those people. But my number one pet peeve, I would say, is not seeing some of those patients who've had pain until about the 3-month mark, right? So what this woman that I saw with the chest pain, she, again, maybe a year she'd had pain before she actually ended up in physical therapy. And by that point, they're already in that chronic stage of pain, right? And hard to reverse that. Easier if we can get them. Usually I tell my patients maybe a week of rest, maybe 2 weeks of rest, but 3 months of rest obviously is not working, right? We need to get you in as soon as we can to start that healing process so that we don't get those brain changes. The other thing, that another pet peeve of mine is having patients who've had pain for years and never seen a physical therapist or a chiropractor or an acupuncturist, just saying, well, that's the way it is. It's just, I got bad knees. But there's stuff we can do about that. I often tell my patients I'm not a miracle worker or a magician. I wish I were at least one of those. I would be making a lot more money than I do. But there are definitely things that we can do to address those problems and at least give you some pain relief. Another thing that I discussed or hit on quickly is the psychosocial aspect of pain. The longer that I am a physical therapist and practicing, the more that I say to some of my patients, especially these chronic pain patients, maybe you need to go talk to somebody. And I think that backing that up from like a primary care physician or a referring physician standpoint is helpful. And I think I need to do better about maybe contacting the primary care and saying, hey, I think this would be beneficial. But they're so, and not to say it's all in their head, right? And I never say that to my patients. But emotional aspects of it can affect their pain and make things worse. So I think that's a really beneficial aspect that needs to be used more. The other thing is, as far as you dealing with patients with pain, tell them your story about physical therapy, I would say. Don't tell them if it was a horrible experience. No, but just saying, like, here, I did it. I went, I felt bad. They did this, and yes, it hurt some, or yes, these weren't, I don't love exercise, but I'm better now for what I did. I think that's really helpful coming from an outside source, and especially from a physician, because your input and your opinion matters a lot. The last thing I'll talk about is I'll have patients come in and say, well, my doctor looked at my x-ray, and they said that was the worst shoulder they've ever seen. And I'm like, oh, God. Let's backpedal a little bit here. Again, here's the mental aspect of it. If you think that, you're a self-fulfilling prophecy, right? And I've actually had, I had a patient last year, I think, a young girl who, I don't remember why she had an x-ray. She had an x-ray of like her back, and they found actually she had a fracture in her back. She didn't know. She wasn't having any pain, but they said, this doesn't hurt? That doesn't hurt at all? No, it doesn't hurt. So she comes to me 2 months later, and guess what she's got? She's got back pain. Because all of a sudden she's like, oh, that I've got stuff going on in there, you know? So I think, I think just, of course not downplaying big issues like that, but also not freaking people out about. One of the things that I'll discuss a lot with my patients as far as especially back pain and MRIs of their back is they did a study that showed 30% of 20-year-olds have asymptomatic disc bulges. 84% of 80-year-olds have asymptomatic disc bulges. So I think, you know, MRIs and things like that, although helpful, can be harmful, especially if people get real freaked out about it. So, but definitely, again, I'm not a magician. There are definitely things we can't fix, and we always refer those people back then to their primary care physician for more input. So thank you for letting me talk today about physical therapy. Have a good afternoon.